And he is an Indian radiologist but with national and international repute, and one of the pioneers of imaging technology in India. He is the founder of Mahajan Imaging, a diagnostic imaging center in Indian capital of New Delhi. And there is hardly anybody who has not heard his name, seen his center or visited his center. He is a former president of Indian Radiological Imaging Association and the director of Department of Nuclear Medicine and Bone Densitometry at Sir Gangaram Hospital. He has served as honorary radiologist to President of India and as honorary consultant to International Atomic Energy Agency. He is on board of advisors of Rishihood University. He has published several articles on clinical radiology and other medical topics. The Government of India awarded him President a body representing the entire ecosystem of Indian healthcare industry. He will be speaking on advances in medical diagnostics.
Thank you. Thank you very much. Thank you very much, Dr. Narendra. Even though the topic is advances in diagnostics, somehow, I thought, let me talk about integrated diagnostics because that is what the future is. And since we are talking about holistic approach to healing, diagnostics will play the same role whether one is treated by an allopathic doctor or a Unani doctor or a homeopath or using our traditional Ayurveda methods. In this era of evidence-based medicine, it is incumbent on whatever field it may be, whatever approach there may be to treatment, to healing, to know what exactly is the problem and to have exact evidence. We all remember when we were young, we would go to the neighborhood family physician and he would have 3-4 bottles, different color of liquid, which would be given. And we didn't know, we didn't care, we had full trust and we would take it and most of the time would get well also. But the whole scenario has changed. People today take doctors to court saying that you didn't treat properly. Despite everyone's best efforts, you may end up having to lagao chakkars of court and all that. And also these technologies were not there at that time. It was clinical medicine that was practiced, feeling the pulse, feeling for the liver, hearing the breath sounds, and with that you had to do maximum you had an X-ray and some rudimentary blood tests. But now in this era of space age, where so many technologies are available for diagnosis, that is where, with the expectations both of the patient, society, as well as of treating physicians also, we have to rely on diagnostics. And I will take you through what I feel is the future of diagnostics, and that resonates with the theme which Dr. Alma started with, integration, integrated diagnostics. And what does that really mean? What is integrated diagnostics? It's combining pathology, lab medicine, radiology, genomics, all together. There is mutual interdependence between these fields, but the touch points, as you can see, are very, very limited. There are deeply integrated workflows and we need to communicate with each other. However, unfortunately, we continue to work in silos. We have to move beyond the traditional radiological, pathological approach and each modality trying to compete with the other. Here again, we have to have a holistic approach and do integrated diagnostics so that we reach the diagnosis as quickly as possible, using the minimum of diagnostic tools and of course doing it in an affordable manner. So this is the current workflow. You have lab medicine, you have pathology, you have radiology, nuclear medicine, you have genomics, and you have the treating doctor. And he has to look at all this data and then try to put it together. It is, I can tell you, humongous amount of data. And for any one person sitting in the OPD, having 5-10 minutes to treat or examine a patient, it is very, very difficult. So what really we need is something that I call an integrated diagnostician. And mark my words, 8-10 years down the line, this will be a new field of medicine. This will be the person in between the treating doctor and all these labs and diagnostic centers who do lab tests, pathology, biochemistry, radiology, genomics. Someone in between who is able to actually assimilate everything, be able to digest all of that, and be able to actually give a holistic diagnosis and not say that there is this mass in the lung. Someone says the WBC level is high, but the ESR is low, and then comes something else, and it's very difficult making sense of all that data. Now, what are the challenges of even this integrated diagnostics? We are talking about a physician or a surgeon sitting in his OPD having challenges. Even for this one person, there will be a lot of challenges. There is just too much data. Today, when we do a CT scan, we have thousands of images. PET CT, thousands of PET images, thousands of X-ray, CT images. Then you have MRI, then you have lab medicine, then you have genomic data coming, which itself, looking at the mutations and trying to make sense of them. And there are so many things. So there is huge volume of data, and then there is variety across patients. Every patient is different. And then there is diversity across different modalities, different departments. So really, if you ask me, there's too much data for human processing. If one were to want to do a good job, probably it will take a few hours and not 10 minutes for a doctor to make even an integrated specialist diagnostician to make sense of data. But at the same time, there is also too little data. We say there is such a huge amount of data, but if we look at it, available data is very unstructured. You do something in one hospital, it will not open in the other hospital. They will say, no, we'll do it again. And so, despite the huge amount of data that's available, it's unstructured. In India, we say we have crores of population, so many people getting things done. But if you were to ask, okay, let's see the chest X-ray of TB patients. Between the report and between the X-ray, there is no integration in any hospital. Very few hospitals, when you say Ram Singh, you may get his written report or you may get his X-ray. Getting both together is very difficult. And this is a fact, not only in our country, but across the world. It's the same in USA. Different EHR systems, different hospital systems don't speak to each other. And so when you start searching, even though there's huge amount of data, you can't make sense of it. There's free text data with person-to-person variation. There is data even within the same hospital, which one department can't get from the other department. And then there is this huge reluctance to share data. Everyone says, ye to mera hai. Why should I give it? As if, and we keep hearing, data is the new oil. And so someone feels ki kabhi ye bikega, aur pata nahi kya ho jayega. Without knowing that when we will ask you for data, you won't know what is what out of the images or lab tests or genomics data that you have. There is reluctance to share data within hospital systems, across hospital systems, of course, across geographies. Otherwise, if we could pool it all together, it would be so much more. And then, most importantly, there's lack of normative data. You know, at 10 years, what is a normal chest X-ray? Or at 10 years, what is normal sugar level? What is it at 20, 30, 40, 50? Normative data is lacking, and whatever. I mean, you'll be surprised. Many of the norms that have been laid have been based on a few hundred patients done about 50 years ago. And we take that as the gospel truth, and that's how we are proceeding. So, I'll say, where's the data? Now, if we take COVID-19 as a test case for learning, the world is going through the greatest crisis. And despite honest attempts of sharing data and experiences and learning from each other in the past 18 months, yet the tools and regulations for sharing, analyzing and decision making across the world have been far from ideal. Despite the fact that everyone wants to do it, to share it, the attempt is honest. Could we have controlled or limited the impact of this pandemic if more robust methodologies, engines of rapid data sharing and disease response were in place? Across the world, thousands of groups have created artificial intelligence algorithms for chest X-ray, for HRCT chest. But have they really made any difference? As far as I know, hardly any one of them is in use, even though thousands have been created. Can we learn from this apparent failure when the intent was right? And I think we need to learn from this. This gives us a great opportunity. And I feel the solution lies in using artificial intelligence, but there are too many algorithms and no easy way for clinicians to access all of them. And then algorithms are very narrow, very niche. It's anatomy based or modality based. It's different for X-ray chest, different for pneumothorax, different for TB, different for lung nodule. It's different for different modalities, of course. For chest, it may be a CT or an X-ray. And most algorithms currently ignore clinical and lab parameters. In the radiology space, this is the truth. I, as a radiologist, if I see abnormality in the lung, the first question I ask, isko bukhar to nahi hai? Is there fever? How is he clinically presented? Currently, AI algorithms aren't able to integrate that. And the same X-ray, as Sushruth will also agree, I may call as a malignancy or I may call as an infective pneumonia if I know the history. And also there is no easy way to test artificial intelligence. There is limited real world evidence and clinical workflow integration remains a challenge. So AI solutions need to overcome technical and integrative shortcomings to be clinically valid and acceptable. Now, if we talk of informatics tools and the clinical diagnostician, we will need real-time data search at patient level, at health system level, at population level, with seamless integration. Single view for all records, investigations, single view for all algorithms and outputs, and ability for new analytic tools to come on board seamlessly. If something gets better, we should be able to assimilate it in the system very soon. I personally feel that this integrated diagnostician, radiologist, would be ideal to play this role because we are already trained in assimilating multimodal data, right from X-ray to PET-CT. There are so many modalities. Radiology has been digital right from the beginning. So we are used to digital data handling. We have also been the earlier adopters of informatics and artificial intelligence, but we need to be clinical radiologists and not armchair radiologists. as many radiologists have become. They don't even meet the patient. They don't talk to the patient. They don't talk to the clinician. They are sitting in their office far away, looking at their computer and writing reports. That won't work. And of course, with artificial intelligence, what happens is the clinician will also be able to use that tool. And if you get a 90% accurate diagnosis, I personally feel the clinician may not need the radiologist. So that's also something which is going to happen in the future, that for many things, just as ultrasound, now the gastroenterologist does his own, the gynecologist does her own. Similarly, it's going to happen with the AI coming in. Now, we are already to some extent there today. If we look at integrated tumor boards, so we have 4, 5, 6 specialists sitting together and trying to reach a diagnosis, trying to reach what is the holistic approach, the correct approach to treating the patient. And this is where, I show you an example, and this is a courtesy of Sectra, where everything, right from the mammogram to the ultrasound to the MRI to the biopsy, all shows up on the same screen. And you can integrate it. Initial, beginning. Now, what we have done, we set up a NGS lab for genomics, next gen sequencing lab, in a radiology setup, the first such in the entire planet, and we are trying to integrate. And then there are ways of integration which I don't think we have time to go into, but merging of imaging, genomics and pathology can increase value across the clinical continuum. Suppose somatic testing for precision medicine, which is expensive, can be packaged somatic testing with follow-up imaging. You do something, you find that this person is at high risk, you say we will do your mammograms for your lifetime for free. Something like that. Now, what happens when an imaging department start running comprehensive genome profiling? You get better biopsies, better tissue, better connect, and hence better patient outcomes. It would also be able to provide single patient-centric window for clinicians. You have one window where everything is presented to you in a pre-digested form, based on which you are able to take a decision. And here I talk of the concept of predictive medicine, which is when you do genomics, you find some mutations based on which, say, someone is more liable to get breast cancer. And then you follow that person up much more diligently than the average lady. Similarly for colon cancer, for prostate cancer. So this is preventive medicine using genomics and imaging. And then you have precision medicine, which is the tumor tissue itself. You send it for genomic testing. Based on the mutations, one can determine whether chemotherapy is needed or not. When it's refractory to chemotherapy, whether immunotherapy will work or not. So the same tumor, which looks the same under the microscope, may have so many different parameters, so many different variations in it. So here, if I were to say that the future of screening and preventive health checks lies in integrated diagnostics, and there is no two ways about that. Genetic risk with exome sequencing, acquired risk, history taking, whether there's smoking, exposure to carcinogens, viral infections, exposure to radiations. Current status you can find with whole body MRI or some other way of imaging. So you can answer this question which is often asked to us doctors. Do I have cancer right now? And what is the best screening protocol for me in the future based on my genomic profile? Right now things are expensive, but as more and more people get this done, it will become affordable. So I believe the hospital of the future will have an integrated diagnostics department which will interact with the clinical departments, and the diagnostics department will have radiology, biochemistry, pathology, genetics all together along with clinical information. You know that line we write at the bottom, please correlate clinically. I think we need to remember that despite all the diagnostics that we have, the history and the physical examination still will continue playing as important a role as it did 50 years ago. Thank you all very, very much for this